A very good evening to all the delegates, moderators, co-speakers, and hosts of CMC Max 2021. I have been asked to speak on why I love general internal medicine. Before I begin my presentation, let me express my sincere gratitude to the entire organizing team of CMC Mac 2021 for giving me this opportunity. It's indeed an honor and a privilege for me. Let me start by reciting a patient story. We will call her PM. She's a 33-year-old female school teacher from Chennai. She presented to us about a year ago with prolonged fever, loss of appetite, and significant loss of weight, all going on for about 2 months. On examination, she was febrile, she was tachycardic, and her blood pressure was 100 by 60 millimeters. She was pale, icteric, had left supraclavicular lymphadenopathy, and hepatosplenomegaly evident on examination of the abdomen. Her investigation showed anemia and leukopenia, elevated acute phase reactants, and a grossly abnormal LFT, direct hyperbilirubinemia, AG reversal, elevated transaminases, and a markedly elevated alkaline phosphatase. CT scan showed additional findings of consolidation in the left perihilar region and lymphadenopathy intrathoracic. To continue with the laboratory investigation, the differential diagnosis made clinically were either a disseminated tuberculosis involving the lung and the reticuloendothelial system or a lymphoma. Her induced sputum was negative for TB-PCR. She had very high levels of lactate dehydrogenase, triglycerides, markedly elevated ferritin, and very high levels of soluble interleukin-2 receptor. The bone marrow showed hemophagocytosis. TB-LB and DBUS showed necrotizing granulomatous inflammation. AFP smear was positive. The TB-PCR was negative, and the culture grew Mycobacterium cansacei. So we made a diagnosis of non-tuberculous mycobacteria, Mycobacterium cansacei causing, infection causing secondary hemophagocytic lymphohistiocytosis. She was treated with INH, rifampicin, ethambutol, and clarithromycin along with prednisolone. And we have been following up for nearly a year now. She's currently febrile, has gained weight. Her CBC and liver function tests have become normal, and CRP and ferritin values are slowly declining. Being fortunate to have a part in the care of this patient is all about why I enjoy being in general internal medicine. If you want to put it together as reasons, there are 4 important reasons. Number 1 is the constant goosebumps I get while participating in the care of my patients. General internal medicine is incredibly challenging, incredibly exciting, and incredibly rewarding. You are able to find and experience joy in the practice of medicine. You do this by not only by playing a small part in alleviation of suffering of your patients, but also actively helping them to reach for joy. So both alleviation of suffering and helping them to reach for joy are an integral part of practice of medicine. And this ultimately leads to finding meaning and purpose in your professional and personal life. Second is the fragmentation of care brought about by the traditional model of subspecialization. So this is what a traditional model of subspecialty does. It's either organ system, disease, or insult based. You have a cardiologist, you have a neurologist, you have a nephrologist, or you have a diabetologist, or you have a trauma specialist. So it's either organ system, disease, or insult based. And this leads to patient-centric, physician-centric approach to both care of the patient instead of the patient-centric approach we actually need. And these are the attendant ills of a physician-centered approach. Medicalization, overdiagnosis. You overdiagnose coronary atherosclerosis, you overdiagnose osteoporosis, you overdiagnose prostate cancer in men, widening of boundaries of illness. You've heard of subclinical hypothyroidism, and you become a seller of sickness, peddler of maladies, and sometimes sickness and wellness are sold to the patient. Also, the drawback of a hospitalist or a proceduralist approach. A patient comes to the emergency department with severe diabetic ketoacidosis. You do a fantastic job of controlling the ketoacidosis, attaining euglycemia and discharging the patient, but you have absolutely no concern about why did this patient develop the diabetic ketoacidosis in the first place and what happened to her after she was discharged from the hospital. Proceduralists are basically concerned about tossing out a damaged organ or fixing a plumber's job, fixing leaks or fixing a stenosed valve. Ultimately leads to fragmentation of care. I saw a patient recently in the outpatient clinic, had proliferative retinopathy, was given intravitreal injections, laser photocoagulation, but this person had absolutely no concern about the patient's chronic kidney disease. And all this leads to spiraling costs. And like a recent book said, practitioners in India see our patients as revenue generators, mere revenue generators. And I would like to quote my teacher, Dr. George on here, that the most important cause of multi-organ dysfunction is a single organ specialist. Contrast this with the approach of internal medicine. So William Osler had this ideal of a consultant generalist, a specialist in general internal medicine. So this consultant generalist has this unique perspective of evaluating a patient across organ boundaries, contextualizes the patient illness within their psychosocial and socioeconomic conditions. So addressing the non-medical determinants of ill health, and you're comfortable with complexity, uncertainty, and undifferentiated problem. Unlike a hematologist who will only treat an acute myeloid leukemia only after the molecular test results are back. Also, a general internal medicine, the specialist is aligned to the needs of the community. So very important point here. In general internal medicine, you also strive to address the inequities. Specialist care can widen the disparities in access to appropriate medical care. Medical care will bring down disparities only if the care you provide is appropriate, is accessible, is affordable, and finally acceptable to the patient. A care which has a specialist, highly trained specialist, with the backup of a tertiary or quaternary center can only provide care, has the potential of widening disparities. So we have to remember the words of both Rudolf Virchow and Dr. Yogesh Jain. Virchow said that medicine is a social science and politics is nothing else but medicine at a larger scale. And Dr. Yogesh Jain from JSS in Bilaspur said that it's mandatory that a doctor addresses social issues and addresses the health inequities. So care which has the potential to widen disparities of care is not in the larger interest of the patient. And finally, the people I have come across, I had the fortune to meet, and some whom I have made friends with. I am humbled by the incredible stories my patients have shared. Intimate stories encompassing the entire gamut of human experience and human emotions. I've been truly humbled by the things they have shared with me. Sometimes I've also been fortunate to be part of these stories, albeit a minor part. I'm grateful to all those patients who have come to me seeking care. I made lifelong friends with some of them. I also had the incredible privilege of being a physician to 3 generations of some families. It's truly humbling when you are involved in the care of a patient and you lose that patient and the rest of the family members still bring the other members of the family for your care. So all this has been a truly humbling experience. So in essence, the journey in general internal medicine has been incredibly satisfying, incredibly rewarding. So this is why I love general internal medicine. Thank you all for patient listening, and thank you once again to the organizing committee for this opportunity. Thank you very much.